key points, because this is kind of like the objectives, but not really. These are the highlights, all right? And then we'll go back and hit all these things specifically. So as you all know, being in the ICU, you can take one 60, 70, or 80-year-old and compare them to another 60, 70, or 80-year-old, and it's night and day, right? It is completely different depending upon their family history, the lifestyle choices that they've made, and sometimes just overall luck, right? If they've been in an accident when they were 40 and they had major C-spine injuries and they've been dealing with those injuries ever since. So you throw all those things in there, and one patient of a certain age is going to be completely different from another person. So it's completely variable. So you need to be able to make your assessment by looking at the patient history in your interview and the knowledge and experience that you're going to be gaining to determine how, maybe we can use the word stable, unstable, your patient is going to be during induction, maintenance, and emergence. And you should know enough by now to realize that that induction part is one of the key times when you can really tank your patient's vital signs if you're not careful. So everybody's going to be different. That can go for any age group, but it really is specific for the geriatric population. Again, we all know that as people age, their organ function is going to decrease, and that's across the board, right? Every organ we have is going to be not as functional as it was 10, 20 years ago. In Apex, it's funny, they have a section in there that says, something along the lines of, I hate to tell you this, but most of you who are reading these study notes already have a decrease in function of, all of your organ systems. Like my stuff, my organs are not functioning as well as most of your organs because you are the younger generation, right? And as much as I try to stay physically fit and drink my rock stars every day and do all the things that I need to do to keep myself strong and healthy, my organ function is decreasing. My cellular structure is degrading daily, and there's nothing that we can really do about it. We can do things to help slow it down, but nothing's going to stop it. The things that we do shouldn't be based on just age. And if somebody, just because somebody's old, shouldn't dictate that we do all these tests just because they're 70 doesn't mean that we throw every test at them in the arsenal. It doesn't have to happen. We'll talk about MAC being decreased. I think it's after age 40, there's a 6% decrease in MAC for every decade of life. That's mentioned twice in the PowerPoint, I believe. So you need to have that in the back of your mind. I don't think you necessarily have to be figuring that out. Okay, this patient is 65 years old. That means there's going to be a 612, what is half of 15% decrease in MAC of this anesthetic. So I have to hurry and calculate that out. No, you just got to realize that they're probably not going to be needing as much as the person that's 40 or younger. There's a handful of information on keeping our patients normal thermic, and that's across the lifespan, right? But it's really important with the pediatric and the geriatric population because they don't have the compensatory mechanisms that the normal adult has to keep the normal thermic, and we'll go over that list that you've seen before on what can happen if your patients are getting too cold. Follow your spidey senses. I don't think we can ever say that enough. If it doesn't look right, sound right, feel right, something's not right, and you need to be ready to fix it or preemptively take care of it so it doesn't go down that path. And then most of the time, less is going to be more. Okay, back to the beginning. Yesterday, just some demographics of aging, kind of some interesting things. The overall take-home message of all of this information is that the geriatric population is getting larger, and it will continue to get larger as the years tick by. Also, the majority of cases that we do are performed on the geriatric population, as that part says right there. 30% of surgeries are performed on individuals over 65. So if the number of patients that are over 65 are getting bigger and we're doing 30+%, that means that we're going to be doing more and more surgeries in the geriatric population. And you'll see that when you're in clinical. A lot of the stuff that we do are on older individuals. So you will get used to dealing with this population and things that you should and should not do, depending on what they have. Here is just some information on the overall picture on the process of aging. We can just talk about how my thing on this, and I'm reading it, is that I should be ingesting more protein because it's the protein that seems to be one of the larger issues with the geriatric population. They're losing muscle mass and everything else. So I need to take more protein because I'm borderline geriatric population. Cardiovascular system, like it says, right? And we'll get into more details of all these things, but everything is your vasculature, arterial, venous, everything is stiffening up. You don't have as much elasticity with it. So you're going to have problems when it comes to the drugs that we give and how these patients are doing. And I love this middle part. The anesthetist can develop an intuitive sense of an aging patient's reserve through simple observation. Those 5 minutes or whatever you're spending in the room, you can get a lot of information just from your assessment skills. And that's why we go over those in arts class, whenever that is, again, just to make sure that a lot of that stuff you've heard before. I'm guessing the majority of it, but it's important that we refresh your assessment skills and make sure that they are on point because we can get a lot of info just from assessing without all that other stuff, without the blood work, without the chest x-ray, EKG. You can look at these guys and get an idea of whether or not they're friable and it's going to be a difficult case because they're not quite as stable as that other 65-year-old that you took care of in the case before this one. Like I mentioned, an aging process is very variable. All right. The one on the left is me after I've just kind of been in the gym for a little bit, just getting a little pumped up. The one on the right is Ted after he's been on his liquid diet for a couple weeks. So you can see the difference between somebody who's young like me and somebody who's old like Ted. There is a significant difference in our how we look and most importantly, your muscle mass to fat ratio, right? So out of Heinz, it just says that that the older population has decreased skeletal muscle mass, as you can see from this picture. Their ability to store lipid-soluble drugs is going to change, okay, because they've got an increased percentage of body fat. Their lipid-soluble drugs are going to sit in that fat longer, which then leads to potentially a longer emergency. Into that case, if all your lipid-soluble drugs have gone into the fat stores, and then you want the case to be done, and it's slowly coming out of the fat stores, it's going to take a longer time for them to wake up and a longer time for them to go home. So just off the top of your head, what is one class of drug that's very lipid-soluble that we would like to hold on an elderly population?
Benzodiazepines.
I heard benzodiazepines. Is that what I heard? That yes. That's the one I'm looking.
Renal function though.
What's that?
I was thinking that's more because of decreased renal function though.
Well, that's also part of it. But we don't give benzos to these patients because of probably a myriad of reasons, but this is one of them, right? Like I had a 60-something-year-old that we took care of earlier this week. We were doing a removal. We're going to have higher blood levels in patients. And why do you think we could have a given dose of a drug produces higher blood concentration levels? What's happening?
Decreased proteins available for protein binding.
Good. A lot of our drugs are protein bound, and we all know that our aging population has less circulating protein. We kind of talked about that at the beginning. So if they're protein bound, less circulating protein, there's going to be more drug just floating around that is not bound to these proteins. So whatever it is that could potentially happen with said drug will happen because it's not bound to that protein. And then like we talked about, because of their malnutrition, decreased circulating proteins, they're going to have an issue with these protein bound drugs because they have more of it circulating. A little quote on binding, protein binding. Protein binding sites reduce secondary to both the amount of what they have and the function of what they have, okay? So those changes are gonna increase the level of free unbound drug in the blood, which then you're gonna have a increase in the effect, which is what we mentioned, I think, a couple slides ago, all based on protein binding. So knowing all of these things, right? You have this now in the back of your mind, you're studying about geriatric patients. How do we apply this to anesthesia in the pre-op interview, right? Knowing that their recovery time is gonna. Now, back to thermoregulation. Like I mentioned, pediatrics, geriatrics are the two populations that are going to be most affected by this. There's that decrease in muscle mass. They're not going to be able to respond to the colder environment as quickly as a younger individual. Like it says here, the initial response to cold environment is to vasoconstrict, and then shivering is second. And if your patients are shivering, we've got them too cold. Now, and personally, there's a difference between shivering because of their hypothermic and shivering because they're coming off of an anesthetic. Because sometimes patients that are normal thermic will still be shivering when they're waking up, and that's just one of the side effects of the anesthesia. So even if we keep our people in the right zone, they will sometimes wake up. They still will sometimes wake up shivering. As you can see here, that that there is a 1 degree, so 1 degree in Celsius versus 4 degrees in other populations for initiation of vasoconstricting or shivering. So their temperature changes just a little bit, and they're starting to get into whatever process they're going to get into to get them to try to warm up. And like we mentioned before, there's a list right here of some things that happen when your patients are hypothermic. Right? MI, infection, bleeding issues, which will then increase blood loss. Impaired drug metabolism. If you are letting your patients, especially geriatric patients, get hypothermic. Any patient who's hypothermic, it takes longer for them to wake up as the volatile is working its way out of their body. Now you get a geriatric patient with the same thing. It's going to take even longer, and so the recovery times are going to be significantly increased. And then the anesthetics, the volatile anesthetics, change. It's the hypothalamus that helps our bodies react to temperature regulation, and the inhalational anesthetics that we're giving will ding that hypothalamic response. So just have that in mind that it's going to be even worse with the elderly population. These are the reasons why that happens, right? There's multiple reasons why we have these age-related changes: less lean body mass, increased fat, decreased metabolic rate, decreased total body water, and overall blood volume are all going to be things that make it why these patients, our geriatric patients, have a higher chance of becoming hypothermic in the operating room. Okay. And then here's that second part that I mentioned. I told you this was going to come up twice, and here you go. That sevoflurane, all volatile anesthetics. There's a decline of 4 to 6% for every decade after 40. So that, just have that in the back of your mind. Your older patients are not going to need as much volatile anesthetic to keep them asleep. So bearish is another one. The first time it talks about a 6% decrease in MAC per decade of life after age 40. Okay, so just kind of have that in the back of your mind when you're doing your anesthetics. And you remember, 6%, 0.06. Let's say you got your 1 MAC of DES, and that's at 6%. So you got your 6% on the dial. So 6 times 6 is going to be on that configuration 0.36. Now you're down to like 5.64 or something, right? So you can see how it starts to just slowly decrease with every decade of life. So as your patients get older, they're going to be at a much higher risk of having emergence delirium, not remembering where they are. But you get that with normal age patients. They wake up and they forget where they are. They forget what they've had done. And so you have to keep reminding them what happened. And they're asking you the same questions over and over. What's the medical term for repetitive questioning? Don't say it, Ted, if you know it. I want to hear it from somebody else. Anybody have it?
There's the P, I think.
Yep. Perseveration.
Liberation. Yes.
And they're going to have a reduced response to beta adrenergic stimulation. What is the most common beta adrenergic drug that we give?
Ephedrine?
Boom, ephedrine. Okay, great. So we're going to have a decreased response to that. We've already mentioned the decrease for the compromised thermoregulation. So there's a whole little bit on that here coming up shortly.
All right, let's talk about Lefort facial fractures. And in about 10 minutes, we'll take another break. So there's 3 common Leforts. The most common is probably the Lefort 1, which is the horizontal fracture that you see on the left. It extends from the maxilla to the floor of the nose and the hard palate. This is a common surgical procedure fracture that they'll intentionally create for some orthodontic surgeries, whether they're trying to set the jaw forward or push it back for underbites or overbites. Oral surgeons will use this technique to where they peel back the upper jaw under the lip and the gum, and they create this fracture with a chisel. And it's kind of creepy, and it's one of those surgeries. You know, everybody has one of those surgeries that's kind of like it turns their stomach, and you're like, oh my gosh. That's the one that almost gets me when I see these orthodontic surgeries where they create this Lefort fracture and they drop that whole upper jaw, and it's just a big bloody mess. And so it just gets me. But you'll see those Leforts used intentionally for oral maxillofacial surgeons to reset their jaw in a different position that, for aesthetic reasons, or multiple reasons actually. Nasal tube, a lot of times used in that procedure because they're working inside the mouth, and so they want that tube up out of the way. Oral surgeons are really good at securing nasal tubes and how they want it. They're very specific on how they want it padded, how they want it taped, how they want the towel wrapped around the head. So you almost could just give them the stuff and let them do it. They're really good about that. But some other surgeons that you're using a nasal tube for probably would rely on you. And then you just have to take those considerations that we talked about earlier with the ulcers and stuff. Hey, Dan, I'm getting some texts from some of the students. Will you come make sure it's... Yeah. Lefort 2 is it's the triangular fracture, and it's running from the bridge of the nose up through the medial inferior wall of the orbit and beneath the zygoma. So it's kind of that triangle one. And then the Lefort 3 is the transverse, and electively you probably won't see these Leforts. You may, but it's unusual. They're less common. Traumatically, you might see these Lefort fractures in a traumatic facial fracture from some kind of traumatic injury, whether that be a car accident or whatever. Keep in mind when you have a Lefort 2 or 3 known, yeah. There's a couple of them on there. Oh, Adam lost internet service, but he's back. We're recording this, Adam, so you can pick up where we left off, whatever you lost. But Lefort 2 and 3, if you know you've got a Lefort fracture, because most of these patients get traumatic patients are scanned, MRI, CT scan, coming in for emergent surgery, whatever. You don't want to do a nasal tube, and you don't want to do a NG tube. Those are the cases that you read about, and there's an X-ray picture out there floating around that you could easily pull up where the NG tube went into the brain and looped up into the brain. And so keep in mind that if you've got a surgeon that wants a nasal tube on a Lefort 2 or 3 traumatic fracture, probably can't do that or shouldn't do that. So. We talked about all this stuff already. Moving on. Suspect other problems in the presence of these fractures. Now we're talking more not the intentional elective creating of these fractures, Lefort 1, but more of the traumatic stuff. You could have a basilarity skull fracture, CSF leaking. You could have, if you've got some kind of brain injury there from the Lefort, if they've got enough trauma to create a Lefort fracture, they may have some kind of brain injury. They may have increased ICP, so you have to take into consideration controlling their ICP. Hopefully, maybe you have an ICP monitor if it is one of those type of traumatic patients, and how you're going to change your mechanical ventilation associated with that to maintain their ICP. They could have, if they've got that much trauma for a Lefort fracture, they could have airway damage, and they don't have an airway in. What kind of things are you going to have to run through? What kind of airway are you going to have to do? And how quickly do you need to get this done? The edema is probably only going to get worse if it's a fairly recent trauma. They may have limited range of motion in their jaw, and you'll find people that have limited motion in their jaw for some of these jaw fractures or zygomatic fractures or whatever it may be. Don't open their mouth very wide, but you'll find once you put them to sleep, and this isn't something to hang your hat on or guarantee it, but once you put them to sleep, you can open their mouth significantly wider because it was associated with pain that they wouldn't open their mouth very wide. But you may have some that might have mechanical injury or swelling that limits their mouth opening, and how are you going to deal with that as an airway expert? You could also, with Lefort 2 and 3 fractures or that significant trauma, you could have cerebral artery injuries. And obviously, cerebral artery injuries are feeding blood up into the brain, and so you're going to have some brain hypoperfusion or hematomas. Hematomas in the airway can deviate your airway off to the side as well as obstruct. And so there's lots of things that you need to consider or think about when you get into these traumatic injuries in the head and neck area. For instance, something like this. Probably one of the worst airways I ever had to intubate was a guy who, in Utah County, this has been a while, 15 plus years ago, was fired from his job and was upset and went to his work and shot and killed his boss and another coworker, and then turned the gun on himself and shot right under the chin with a hollow point close range pistol. And it did not enter his brain, but it went through, ripped his whole front of his face off, up through his forehead. You could see kind of you could piece together a mouth a little. There are obviously 5 different kinds of hepatitis. The first 4 are the most common in the United States. E is actually obtained outside of the U.S. It's more notably in Central America and South America and across the waters a little bit. Very unusual to have it here in the United States. A, B, C, and D are your most common. A being the fecal oral route that sometimes you will hear about these outbreaks at restaurants or fast food restaurants from poor hand washing. I don't want to make you guys never want to go eat out at a fast food restaurant ever again, but that's usually where those outbreaks will come from. Very low fatality rate, and it's typically not associated as being chronic. B is parenteral or sexual, also a low fatality rate, a little higher in chronic rate. But when you look at C, or the non-A, non-B parenteral, very, very low fatality rate, but look at the chronic rate associated with hepatitis C. 70 to 80% of these people that obtain Hep C have chronic issues associated with that. And so those are the people that are going to be potential have all the issues associated with hepatitis or chronic hepatitis, and they'll deal with it probably for the rest of their life. And then D is your highest fatality rate associated chronic hepatitis, and the parenteral. I got to move the pictures, you guys. It is 2 to 7%, but the sexual side of that can be chronic for up to 50%. You must have hepatitis B if you have hepatitis D. So those kind of go one with the other. They're kind of joined together. And then just for information, E is also a fecal oral route obtained out of the outside of the U.S., like I mentioned earlier. Okay, so what are some of your anesthetic considerations for hepatitis? We've covered some of this, obviously, but never can cover it enough, because these are going to be the things that you're constantly thinking about when you go out and evaluate your patient for whatever procedure, whether that's a procedure related to their chronic issue or condition, or even just a bone fracture or something, but they've got this chronic issue. So during acute ETOH intoxication, typically you'll avoid elective surgery if it's an acute alcohol. If it's chronic, then you're going to decide if you need to do that emergently or if they need to be tuned up with all their chronic issues they have. Do they need to be given FFP and fix their coagulopathy before they go to surgery, or is the surgery urgent, emergent, that you need to maybe do that at the same time as the surgery? So there are a lot of considerations that you have to take into account when deciding if you're going to move forward with these type of patients or not. As part of the tune-up, you may give them some kind of albumin treatment to help pull up their albumin level. You're going to check their LFTs, their CBC. A lot of these patients are anemic when they get into the chronic state. Do they need blood transfusions before they have surgery? Are their electrolytes off? Do you need to correct those at all? The serum ammonia is a late stage, and that it's the ammonia that causes the encephalopathy associated with chronic liver and hepatitis issues, where you get the confused, sedated patient from the encephalopathy. Can't say that word. You're going to typically judicially treat these guys with lots of IV fluids. They have a big fluid shift, especially when you get into the end stage chronic liver problems, when you start getting the ascites or the distended belly from all the fluid in their peritoneum. And when you start getting that big fluid shift, that's usually when you start having the electrolyte issues as well. And then again, we talked about the FFP and the PAC cells, the cryo, but some of these patients, if you have time, you may give them just vitamin K, but vitamin K takes a while, right? It takes a little longer than giving them FFP. And for the most part, these guys with their fluid shifts can tolerate the volume of FFP, as opposed to some of those chronic heart failure patients that have coagulopathies, and you have these surgeons that want to dump a ton of volume in FFP to kind of correct their coagulopathy so they can do surgery, and they put them into a worse heart failure patient. These guys typically can tolerate that volume for the most part. Now, having said that, you still can have in end-stage renal or liver disease, you can have heart failure as well in the end-stage issue, so you got to evaluate that as well. And one of the other things, and I can't remember if it's in a slide coming up or not, is you can get the renal failure associated with chronic hepatitis or liver failure associated with the fluid shift and the kind of the vascular compression and decreased blood flow into the kidneys that can cause transient renal failure. And usually if you can fix the fluid shift on the liver side of it, it will correct the renal side failure issues that you can have with these patients. I think I have a slide coming up that talks about that a little more. On the chronic side, or acute side, we're talking acute, less anesthetic is needed. These patients are more prone to aspiration. A lot of these patients may be you have to evaluate, do they need a rapid sequence induction for general anesthetic, and how you're going to run through that and do that. Surgical bleeding may be increased for obvious reasons with the coagulopathies. Their brain is less tolerant of hypoxia. You want to keep these guys normal capnic, and so you just want to maintain their normal baseline blood pressure as best as you can, and their normal baseline CO2 and capnia as normal as possible for where they normally run. They have increased level of circulating catecholamines. They have about a 10% mortality, 12% morbidity. Surgery during alcohol withdrawal, though, can change that mortality all the way up to 50%. So if you've got somebody that is in full alcohol withdrawal, you're going to probably want to that'd be the case you'd want to optimize and get them through that withdrawal syndrome before you do surgery, if at all possible. Okay, acute hepatitis. You'll find that the book says use ISO over DES and SIVO. There's a lot of talk of halothane when you talk about liver, and in Apex, on one of the pictures or slides in Apex, it said you will never use halothane, but they're going to probably potentially ask you about it in boards because halothane is not used anymore. But there was the common term associated with halothane called halothane hepatitis. So halothane itself could cause hepatitis that was highly metabolized in the liver. And so on liver cases, you would use halothane. Now, you guys won't even come across it, but for boards, you'll need to know about halothane and halothane hepatitis and why it's avoided. ISO is the best choice if you have the choice of ISO in your facility for chronic hepatitis or liver problems. But you may come across a lot of facilities that may not even have stock ISO anymore. It's less and less common just because SIVO and DES are so much quicker on and off that's kind of become more of the norm to use for most cases. ISO is the cheapest, so on long cases, bigger facilities, they may still use quite a bit of it because it will reduce costs significantly. Again, maintain normal capnia, provide adequate liberal IV hydration. We've talked about that previously. Consider regional. Obviously, regional would be a great option for these guys as long as their coagulation is acceptable. And then avoid medications that inhibit cytochrome P450, such as halothane, again, which you won't come across. Tylenol, sulfonamides, tetracycline, penicillin, and amiodarone. Obviously, if you need amiodarone, you're going to use it. It's part of your ACLS. Patient with acute hepatitis, thoughtful titration of neuromuscular blocking agents because they may be prolonged. Again, we've talked about that significantly. You can have reduced cholinesterase activity. So if you have reduced cholinesterase activity, what neuromuscular blocking agent are you going to be concerned with?
Oxydoncline.
Correct. You'll have decreased biliary excretion, larger volume of distribution. Those are your three things that can kind of mess up your neuromuscular blocking agents, and potentially some of the same things that might affect with that volume of distribution, the amount of medications you may need in some other areas as well. Surgical decompression procedures. So this is a fairly common procedure, and in my mind, it's a nightmare. I hated doing these TIPS procedures for several reasons. One of them was because it's not done in the OR. It's done in radiology, usually with an IR guy. And a lot of times where I've done these and where I trained, they wanted to do them under sedation. One of the sites that they use for access is in the neck to throw these catheters down. And so the patients are just lightly sedated. They're working right there close to their face. Not only are they doing catheters in their neck, they're using groin lines as well. The patients are uncomfortable. And when they start getting into occluding some of these portal veins to try to decrease the pressure and change the flow and whatever they're doing down there to do that, it's uncomfortable for these patients. And they are just, the ones I've been involved with, some of them under sedation, they scream and they're uncomfortable, they're moving, and they've just been nightmare cases. And not only that, they're at high risk for hemorrhage, and you're out of the OR, out of your element, and you have literally no help, at least comfortable help. Typically you have issues over in radiology. A lot of those people really don't know how to help you in those emergent situations. And so it just can be kind of a nightmare case and uncomfortable to do. And so since I initially trained on these, we started doing these at Ogden Regional, where I was working a couple years ago, last year, and we started doing general anesthetics on these, securing the airway, taking an anesthesia machine over, and just not doing it under light sedation because the patients didn't tolerate it. And it works a lot better and it's a lot more comfortable, but you're still out of your element. And if you have an emergency or a massive hemorrhage, those guys aren't the best people to be on your team when you get into those situations. And so
got to know who you can call and get over there to help you if you need to. It's a primary therapy. It's elective for portal hypertension. Again, it's usually offsite, like we talked about, and they access the neck. You can use LRNS, maintenance fluid. Either one's okay with their electrolyte issues that they potentially could have. So you may want to take in consideration if they've got chronic renal failure associated with their end-stage liver and portal hypertension. You may want to use NS and void LR for potassium reasons. But for the most part, most of these patients, you can use either of those. Diverticulitis and diverticulosis, very related. One kind of can potentially cause the other. Diverticulosis is the outpouching of typically the colon. But you can get these pouches up in the esophagus. They may call it something different, but it's kind of the similar process where you get these outpouchings and food can get stuck down in there. And at some point in time, they may get diverticulitis to where one of these may get all inflamed and infected, and it may even perforate. And at that point in time, they may get a bowel resection and come in with peritonitis and be really sick. People with diverticulosis are a little higher risk for diverticulitis at some point in time, and probably get a bowel resection at some point in time when you start seeing this. And it's very interesting when you see a colonoscopy, and a normal colonoscopy is just a nice smooth colon. As they go up through it, when you get people with diverticulosis, all of a sudden you get almost looks like these carinas everywhere, like in the trachea, where you just get these break off at different passages, and they have to figure out which passage is the right direction to put the thing up so that their scope doesn't perforate their bowel if they get into one of those diverticulums. And that's kind of a normal picture there. That doesn't show any diverticulosis, but that's a normal smooth looking picture. And they use that air to expand that out to push that scope up through there.
Okay, looking at, again, these definitions, there's a whole bunch of them that we can look at. And most of the time we're looking at ideal body weight or lean body weight. We're looking at things that are going to be mostly used for, drug calculations or how much we're going to be doing. So I think the three most common weights that we're looking at is obviously total body weight, ideal body weight, and then there's another one, lean body weight. And in a couple of slides, it'll show you which drugs are used for which one. On this next slide right here, it has some of the drugs that I'm talking about. So if you look at the bottom, you've got ideal body weight, lean body weight, and total body weight. So, and this list is a nice list. I like how it's, because these are really some of them are the most common drugs that we use in the OR. The ones I want to really to make sure that you have a grasp on are propofol. So we're looking at lean body weight on our induction dose, right? Because we're not really caring about what this increased fat does. Remember, lean body weight is your body weight, total body weight minus the fat. So you get rid of the fat, calculation wise, and now you're looking at what the lean body weight is. So we're not looking to dose up the fat with propofol. We're looking to dose up everything else. Sux is based on total body weight. Rocuronium is ideal body weight. All those paralytics are. Fentanyl is total body weight. Sufenta, Remi. Down here in the Sufenta, Remi, fentanyl, and Dex, we don't use those near as often. But the propofol, succinylcholine, rocuronium, sometimes Vec, and fentanyl are the ones that we use a lot. So just have, in your memory banks, kind of which weight you would use in theory to dose up your patients. And I say in theory because we have to have a basis for everything that we do, which you have now seen amply since we've been in school. So we have somewhere that we have to start, and then as you get more experience, you will then see what it is that you should be dosing at. And this is, maybe anesthesia per Dan, but let's look at propofol, for example, and like a pediatric patient, right? I go way above what the induction dose is for lean body weight because I found that the patients do significantly better on induction and during the first part of the case if I go heavier on the propofol. The vital signs stay fine and everything is okay with these normal, healthy kids. But you have to have somewhere that you start. And so this is kind of one of those guides that gives us that direction. Sorry, I want to make sure I don't miss anything here as we go back and forth. Here is a list of all of